Oh, thank you so much, Katie. It was really lovely to meet you, and it's really lovely to be with you all today. So thank you for inviting me. Today's session is going to be quite interactive. I'm hoping that we'll get some interaction from all of you. I'm just going to share my presentation because we've got until 12:30. I just wanted to check whether we wanted to give people a break, you know, a couple of minutes break, maybe 45 minutes into the session, so they can just stretch their legs and just grab a drink or something, if that would be helpful. It's that time of the morning, isn't it, where we all need a bit of caffeine and a bit of a break. So we'll try and break at about between 11:45 and 12, and just break the session up a little bit. So I'm just going to share my slides. Hopefully everyone can see those. Right, hopefully you can see the slides.
Yeah.
And I will put it into presentation mode. And this is where everything goes blank for me, because as soon as you put it into presentation mode, I can't see any questions or chat or anything. So if there are any questions, then just let me know. All right, I'll see if I can get you on another screen. Yeah. Is that working? So, yeah, so just a little bit about myself. I'm working at Coventry in Warwickshire NHS Trust, and I've been here for 11 years, but I do have 20 years of NHS finance experience in the acute sector. And what I want to go through today is, and I'm going to come off this snazzy screen and go to our next one, is talk a little bit about the context of NHS finance, because I think it's really important. Katie, you're right. Can you?
I was just going to say, I don't think we've got your presentation mode open on our screen. So
oh, is it not? Okay, let's try again then. I'll start again. It's just the presentation mode goes a bit strange, doesn't it?
It sends it to you, doesn't it?
Right, okay. I'm going to stop sharing and share again and see if that works. Share. Is it working now?
Perfect. Yeah, thank you.
Oh, fabulous. Brilliant, brilliant. Okay, so what I was saying, that we're going to do a little bit of background around NHS finance before we get into the crux of spreadsheets and budgets. I wanted to give you a little bit of an overview about the NHS structure and how the money actually flows, because I think when we've done this in the past, we want to kind of make sure that you've got the kind of background in terms of how the money flows and how the money actually works, because a lot has changed over the last few years and it can get quite complicated, and then it will put everything into context when we do the budgets and spreadsheets later on in the section. So hopefully everybody's happy with that. What I wanted to do is, we've got quite a lot of people on the session today, and I just wanted to see with a show of hands how many, if just show your hands whether you're from a clinical background or operational background. So we've got quite a mixture of both operational and clinical background here. If I ask you to put your hands down unless you've got a question now, that's brilliant. So I'm assuming those hands are not, are they for questions, or are they for just saying where you're from, whether you've got clinical or operational background? All right, some questions. Aoife, I'm not, will you be happy to interject if there's any questions in the chat, if that's okay?
Yeah, sure, no problem.
Yeah, that's brilliant, thank you. Okay, so what this presentation is aimed for is for those people that don't have that much knowledge of NHS finance and what budgeting and spreadsheets are about. So what we're going to do first of all is just have a quick look at the NHS structure. Just go back into presentation mode. Has this slide moved on for you all?
Yeah.
Yep, brilliant. Gets a bit confusing when you've got 3 screens in front of you. Right, brilliant. Okay, so we're going to do a little bit of background in terms of the timelines because this is really important. Obviously, we have the timeline of when the NHS was first created in 1948 and up to the current time in 2024. Now, the reason for going through this timeline is that we have lots of different political influences affecting the finances within the NHS. So we know in 1962 we had the hospital plan. So 1948 the NHS was actually born under the Labour Party's political influence through a report that was written by Sir Beveridge, if you remember, and that was the real political movement for creating the NHS, free care for all. And obviously there's been a lot of influence since 1948. We had the hospital plan in 1962, and I think that was under Conservatives. The health authorities were formed in 1974, which again was under a Labour government. Then you had the internal market in 1990 under a Conservative leadership. And then in 2000, we had the NHS plan under Tony Blair, again, a Labour initiative. And then the Lansley reforms in 2012, and then the Health and Social Care Act in 2022. And what we're trying to identify here is the fact that the NHS is often used as a political vehicle. And if you cast your mind back to the 1970s, we had a lot of long waiting lists and we had a lot of patients waiting for treatment. And I think when the Labour government came in the 2000s was to pump quite a lot of finances into the NHS. We found that we had a new payment system, payment by results. You know, there were a lot more targets in terms of waiting times being reduced. We had referral to treatment targets. We had all the A&E targets. There were a lot of targets accompanying a lot of funding to try and bring those waiting times down. But what we've seen obviously since then and now is a lot of pressures within the NHS. We've obviously seen COVID. We then had a long-term plan that was published in 2019, a 10-year plan. That was just before COVID. And then obviously now what we're trying to do is get back to what we call pre-COVID levels. So there's been quite a lot of yo-yoing in terms of leadership in government, but also how the financing of the NHS has worked. And we'll go through that in the next slide. But I think it's quite important to see that, you know, the NHS is quite a large political vehicle. It's, you know, the largest employer in the NHS. We have 1.4 million people employed in the NHS, and we manage a budget of 165 billion pounds a year, which is quite a large amount of money. It's actually the 5th largest employer in the world. So that just puts into context, you know, the size and the scale of the UK NHS. So I'll just quickly move on to the next slide, which gives you a bit more context around the kind of world of finance. We're kind of 3 different worlds, really. There was the world before COVID, where, as I said before, in the year 2000, just after the year 2000, after the Labour government came into power, they introduced what was called payment by results. And I'm sure most of you will know that's PBR, that's all about tariffs, and where the money was following the patient. The more patients we saw, the more income acute hospitals and other organisations would receive, and that kind of set up a kind of competition market environment for you know, encouraging us to see more patients because the money would follow the patient. obviously then when we entered the pandemic stage, that kind of ceased and it kind of dwindled away, and we're into what was called a block payment, where hospitals were just given a block amount of money to treat the patients. And some of the things that were, some of the kind of targets that were implemented with payment by results were kind of relaxed a little bit, because obviously the the incentive was all about treating patients and just making sure that we were just being able to function really during the COVID era. And then what's happened post COVID, in that sort of third section, is really we've kind of entered what's called like a new world or a new normal, where it's kind of a mix between block payments and payment by results. I'm sorry, I hope it's not too noisy in the background. It's just that I can hear it. Perhaps you are all okay. You can hear me clearly.
It's all good for us.
Oh, that's great. And so we're in this phase where we've got a mixture of payment by results and a mixture of block payments, because what the NHS finance function are trying to do is get back to normal. If you're in a sort of senior clinical or operational role, you'll know about elective recovery targets and getting back to pre-COVID activity levels. And what we're finding is that we're being asked to do more activity and see more patients and reduce the waiting lists, you know but the funding doesn't always seem to follow, and that's the kind of constraints that we're in. So I think what I'm trying to explain here is that NHS finance has to adapt to what's happening in the external environment. And where we are at the current moment is that we have got very excessive waiting lists. We've got patients waiting over 104 weeks, over 2 years, and there's a real push to get back down to sort of 65 weeks and 52 weeks. Whereas if you rewind 20 years, we were at RTTs of 18 weeks. So a lot has happened, I think, over the past 5 or 6 years, and I think we're just trying to get back to normal, if that kind of makes sense. So I kind of highlighted in this slide here the kind of key things that are happening, or that have happened over the past 3 or 4 years. So if that kind of makes sense, I'll move on. And so what are the kind of pressures that you as operational and clinical colleagues are facing within the kind of financial constraints? I mean, you can see there's a number of pressures there, and none of these will come as any surprise, where we're trying to manage our demand, our waiting lists, the complexity of our patients against the kind of financial backdrop of financial controls and worsening financial positions, because we're trying to recover from the pandemic as well. So completely sympathize with you. I've worked with a number of clinical groups over the last sort of 20 years, trying to manage this. It's a conundrum really, isn't it? On one side you've got patient safety, quality, and then on the other side you've got the finances, and just trying to balance those. And it's trying to, as a finance expert within the NHS, as a business partner, I think it's really important for us as accountants to understand the world from your perspective as clinicians and operational managers, and all the conflicting demands and pressures that you have, and how we can kind of help you to get through managing your budget, as well as being able to deliver on all the other kind of targets that you have. So that's one thing I think is really important, is having that relationship and that understanding of your world, and trying to manage all of those pressures within the current financial constraints. So that then leads on to so what is our aim from a financial perspective? It's all about and I think this is really, I would say, it's a kind of joint it's a joint objective really, is to provide value added service to our patients. You know, we all work for the NHS, and the reason why we work for the NHS is because we want to put something back into the community. And whether you're working in a clinical setting, operational setting, you know, you're at the front line seeing patients face to face on a daily basis, whereas as accountants or people that work in NHS finance, we're kind of in the background, but we're trying to help you and support you with the resources that you need to be able to provide that value to the services that you provide to your patients. And I think in a lot of organisations, if you look at your trust values, it's all about putting the patient first. You know, quality and outcomes, you know, are at the forefront of that service. So with that in mind, I'm just going to do a bit of interaction here. When we talk about value within the NHS, there's a kind of a formula, if you like. It's into what do we mean by value, because you know it's a term that can be used quite interchangeably. How do we define value? What does it mean? Value for who? And so we're going to have a little bit of interaction and say, well, if we interpreted value as a formula, what would be at the top of the formula and what would be at the bottom of the formula? So I'm going to open it up to the chat and see if anybody's got any ideas in terms of what they think would be, if you had the top of the equation being the outcomes, what kind of outcomes would you want to see in terms of good value for money and best value for money? And you know, that's great. Yeah, so we've got a few ideas coming up because I've managed to sort out my screen, so I've got my presentation, I can see the chat as well. So yeah, fabulous. So we've got outcomes, safety, patient satisfaction, loads of ideas coming through. Yeah, you're all really correct. So wow, loads of ideas coming in. Yeah, so I'm going to put you out of your misery and show you what the key thing is. Quality of outcomes. That's quality of outcomes for the patient, is the outcome that we're looking for. And yes, quality of life, patient experience, that all feeds into what we mean by quality. And I know as clinicians and operational managers and service managers, you know, that's the first thing that you look for. And then secondly, then if we look at the denominator, so quality over what is the input? What might the input be in terms of when we're looking for value for money as being the denominator? So again, I'm going to open it up to the chat to see what you think, what the input might be. So we've got admin. Oh wow, the chat is going so fast. I'm just trying to keep up with it. Resources, costs, resources, waiting times and cost per patient. Yeah, that's great. You've all of you that have entered on the chat are absolutely correct. It's all about cost. So when we talk about value for money for patients or value added services, we're talking about providing the best quality of service and outcomes to our patients and service users for the most efficient use of resources. And so cost includes resources, and that could mean, you know, staffing, premises, use of drugs, all of those kind of things. And I'm going to break this down a little bit further, because this also kind of feeds into the term productivity. So you might have the word, you know, word productivity being bandied around quite a lot, and efficiencies. And when we talk about quality of services over cost coupled with productivity, what we mean is that we are able to provide the same quality and outcome, or better quality of service and outcomes, for the same cost, or the same quality and outcomes for a lower cost. So it's always about being more productive and using our resources more wisely and efficiently. And we're going to break down quality into a bit more detail here. So we can break that down into clinical outcomes. So that's, for example, we might invest in a robot to do prostatectomies, for example, because that costs more money, but we get better clinical outcomes. And so clinical outcomes is one of the key drivers of quality. And I think a lot of you in the chat did mention patient experience. So that's a real key indicator of quality of service to patients. I think a lot of organisations do value patient experience and patient feedback. It's something that the CQC looks at as well. So that's a real key factor in one of the factors of good quality services. And then patient safety, by no means least. Again, you know, that's a really, really important factor. So these are three kind of major aspects of quality service, and obviously there's going to be more, but these are the three key ones. And I think that some people have got some notes in the slides about intervention and mitigation are fundamental to controlling costs. Yes, absolutely. That's absolutely really, really important. And that all kind of feeds into the outcomes and patient safety, where as clinicians you have to make those interventions and those important decisions about what the outcomes to your patients are. And that world can be quite complex when you're looking at things like NICE guidance and you want to, I don't know, prescribe the best drug, you know, that's available, and you have to jump through a number of different hoops because of the cost of that new drug. It's a high cost drug, it's a new drug, and you know, it's a better clinical outcome for the patient, but then you have to get approval from through your organization about being able to administer those new NICE guidance and things like that. So I totally get that in terms of working with clinicians on those sorts of aspects. So I've got some comments in the chat about the slides. So yes, I will circulate those at the end if that's okay, or during the break I'll send those out. It's just that I've got animations in the slides, and they might be a bit too large to circulate as the actual presentation, so they might come out as a PDF without the animations, but I'll get those over to you as soon as possible. I'm guessing that you're enjoying it so far then. And then I'm going to talk about costs and resources now a little bit. So what do we mean by costs? So revenue costs and capital costs. I don't know if any of you know the difference between revenue and capital. So revenue is your day-to-day running costs. Now, if you think about this, 165 billion pounds we spend a year on NHS running costs, and that talks about paying staff, paying for drugs, paying for equipment, paying for consumables, all those kind of things, paying for things like heating, lighting, all those kind of things, running, you know, the running costs of healthcare organisations. And if you think about it, 70% of that goes into staff pay. So paying our doctors, nurses, AHPs, pharmacists, you know, all the people that work in the NHS is about 70% of that 165 billion. And I say billion because I'm quite used to saying million, but it's not million, it's a billion, 165 billion pounds a year, just rising. And then we talk about capital costs, and capital costs are investments that we make. So they're like one-off costs. You know, how much does it cost to build a new emergency department, for example? You know, we've just invested 15 million pounds into creating a new emergency department to help patient flow in A&E. It might mean £5 million on a new theatre suite, because the current theatres have been around for 20 years and it's falling apart, or we need to invest in new technology, for example, a robot to do theatre procedures. And you know, there's a lot of state-of-the-art things that are coming online to help us with the outcomes, as well as reducing the revenue cost, but that requires capital investment. And when we talk about capital costs, we tend to have to do what's called a business case to say that we'd like to invest X amount of money in an investment that is going to provide all these patient benefits. And usually, I don't know if any of you have been involved in developing services for your organisation, and whether you have had experience of being involved in writing a business case, but you know, there's always a financial element to that, in terms of, okay, yes, you'd like to invest in this new theatre. It's going to cost X amount per year, and it needs a capital outlay of X amount. How are we going to pay for that every single year? Where is the activity going to come from? What are the additional running costs of that? And it all has to balance and make sense for the investment to be approved. And I think that you might have another session on business cases, have you, Katie, in Proud2bOps? I don't know whether you've already done it or whether that's one that's coming up.
I think that's the upcoming session on the 29th.
Oh, brilliant.
Yeah.
So you'll learn a bit more about business cases. So that's going to be really informative, because sometimes we do have to invest, even though funds are very, very restricted within the NHS, especially capital. You'll hear that, you know, there's not much capital around. Business cases, it takes a long time for many business cases to get through, because we have to absolutely make sure that what we're investing in is going to be value for money, and it's going to produce those outcomes that we are expecting from that investment, which is all about better clinical outcomes, savings in revenue costs, better patient experience, and increased patient safety, along with all the other, you know, things like reducing waiting times and things like that. So that's just a little bit, just wanted to emphasize that a little bit, because I think it sets the context around why NHS finance is so important, and the context of it when you're looking at this from your budget perspective, because you can apply all of this to your daily budget. So to summarize, we have this little motto that, as clinicians and operational managers and specialty managers, and you know, if we're on the front line, and even if we're not, actually, what we need to be is clinically driven, but also financially aware at the same time of all the things that are going on in the background in the financial environment, because how can we treat patients with the best value and provide the best value of care with the best clinical outcomes and at the best possible use of resources? So if you're aware and have been through CQC, they always look at use of resources as well. It's not just the clinical side and the safety side, they look at use of resources as well. So that's really, really important. So I'm going to now enlighten you with a short video, which it's a short animation. I think it's about 2 minutes long, if that's okay, which just talks you through how the money flows in the NHS. I mean, I've given you a really quick overview and a quick run through, but I'm just going to see if this works. I'm going to stop sharing my screen. And I'm going to share this video instead. So give me a moment. Right, here we go. Let's see if this works. All right, hopefully you can see the screen. And I'm going to press play.
This animation gives
That
an
worked,
overview of the
Katie?
structure of the NHS in England
Yeah.
and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years, to create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England and, in the most part, integrated care boards to the organisations that provide patient care.
Hi. I hope you all found that really helpful. The reason why I wanted to show you that video was to plug the fact there are so many resources within the Future Focus Finance website, lots of animations like this, as an example. So if you would like to register, these resources are available free to everyone at no cost. You just need to create an account and you can access all these different resources and animations which help to, put some context around your understanding and help you understand the NHS finances in a lot more detail. So yeah, I just hope that you found that really useful. I'm going to stop sharing that now and go back to my presentation. Just give me a moment, please. Right, I think I'm back on my screen and I'm going to continue from there. There we go. Are you able to see that?
We might have the other view again.
Oh, is it? I don't know why it does that. It's really
No,
weird.
it's a pain, isn't it?
Okay, let's try again from the current slide. Let's try that again. Resume slideshow. Okay, let's stop sharing and try again. I don't know why it does that. Okay.
He doesn't like to make these things easy for us, does he?
Let's try again. Stop sharing, share. Okay. So you can see it in the window, yes?
Yeah.
So I'm going to change it to present mode. From current slide. It's not doing it, is it?
No. Is it opening up on another screen for you? And we've still got you.
I might have another way of doing it. If I just share my screen rather than the actual window, that might work. Let's try again.
Someone's saying press F5 in the chat.
Oh. Oh dear. Let's have another go. Let's try it this way. Right, I'm gonna do F5. I'm gonna try it, see what happens. F5 hasn't worked. I'll tell you what I'll do.
It said sorry. It's worth a try. It's worth trying these things.
Yeah. Okay, let's see what we can do.
Are you doing it
Let's
by
try.
clicking the share button within PowerPoint? You see on
I
the top?
am. Yeah, I am.
Yeah, that should be working then, shouldn't it?
Yeah. So let's see. The presenter mode is on the screen. I mean, does it bother you if it's like
We can
this?
see it in that
Are
way.
you
It's
sure?
fine with me,
Okay.
yeah.
Sorry about that. Because it's in presenter mode. Don't know why it's doing that. Okay, right. That's threw me off a little bit, but nevertheless, right. So we were talking a little bit about in that presentation, it gives you the context about where the NHS finances come from. And what we're trying to get over to the audience is the fact that the NHS is managing quite a lot of funds and there's quite a lot of political influence. As you know, it's, as governments change, the policies change, the funding changes. But what we've seen in the kind of last sort of 20 years is that the demand for NHS services has grown exponentially and the funding has either flatlined or decreased because of world economic pressures. And what that's created over the last sort of I'd say over the last sort of 20 years and more so in the last 10 years is they call it there was a £30 billion gap at one point in 2000 and I think it was 2010 when they had the long-term plan. No, sorry, 2019, the long-term plan was produced, but earlier than that, I think it was 2015, we had the 5-year NHS plan, the 5-year forward view. And all of these papers and policies were all about trying to get the NHS deficit down. And what's happened is obviously, as I said before, we've had COVID and we've had lots of changes in legislation and lots of different ideas about getting the deficit down. And some of the things that have come about is obviously increased accountability, increased scrutiny. And the other thing that we've changed is structural change in terms of managing the NHS. And you saw in the presentation, it talks about ICSs and what is an ICS and the difference between an ICS, an ICB and an ICP. And I'm guessing that most of you on the call will have heard what an integrated care system is. It's basically a governing body that controls all of the finances within a region. So, for example, within a locality. So, within Coventry and Warwickshire, our integrated care system is the Coventry and Warwickshire and ICS, and it works a little bit like health authorities did, if you can remember health authorities back in the day, where the members of the ICS include all of the hospitals in Coventry and Warwickshire. As an example, so it will include the 3 acute hospitals, the mental health trust, community provider, community services, and also all of the GP practices and all the other healthcare services that are provided within Coventry and Warwickshire, and they're all governed by an integrated care system. And this will be true in your own localities and your own regions. What that means is that any financial decisions and any budgets first go to the ICS, and then they determine what each of the organisations' budgets will be and what the control total or the envelope of the budget they have to work to. So this is so we talked about the NHS budget of between 160 and 176 million, and that's just technical really. Contextually we're talking about a lot of money, but technically it can change depending on whether they separate out NHS from social care. But what we're talking about here is NHS funds get allocated through NHS England to the ICS, and then the ICS has to balance its books. So within our Coventry and Warwickshire system, you may have, let's just say, for example, 2 hospitals are overspending against their budget and 2 hospitals are underspending. As a collective, the ICS has to balance. As a collective and a total, the ICS has to balance, because that's what the NHS are governing, that the ICS can control its finances. It's a bit like when you look at your own budgets, and we'll come on to that when we do the budgets and spreadsheets. The same principle applies, that as a service, for example, I don't know, let's just take women's and children's service as an example. As a specialty, you have to balance the budget overall, and it might be balanced, but within that you might have certain services like neonatal unit or PICU or midwifery services. Some may be overspent and some may be underspent, but as long as you're balanced overall as a budget, you know, that's the way that the NHS you know, allocate those funds, to say that you're going to be monitored at this level, but you need to make sure that you're balanced. And same for us as a hospital, we need to make sure we're balanced so that overall the ICS can balance their funds, and so that it's not overspent. If you rewind, I don't know, maybe a decade, we had the situation where the first time ever you had foundation trusts and NHS trusts reporting deficits. You know, it was unheard of. And that's when we sort of entered that kind of decline into, you know, finances, where the financial situation became a lot bleaker. And I've noticed in the chat, while you were all watching that video, a lot of you have posted the fact that, you know, your business cases aren't being approved because there's lack of funding. So, you know, we're in that really adverse financial situation where there is no money, a lot more pressures, all of that. So ICSs were created to provide a little bit more accountability and a little bit more focus around how we can manage the finances within systems. The main reason for doing that was to promote collaboration and working with each other, because if you think about having to meet your waiting times and being able to discharge your patients into the community, you know, it's about us working with our partners to provide the best, coming back to the value equation, best quality of care for the patients with the best use of resources. You don't want people waiting in a hospital bed waiting to be discharged because another provider can't provide the provision for that patient to be discharged, like for example whether it's an elderly care home or a community rehab provider. So this was all about promoting collaboration, and the funds could move in between those different organisations depending on where the need would be. And this is really important to allow that flexibility. And then you've got the elimination of competition that was kind of created by the payment by results world, that was all about, let's see how many, you know, let's steal everybody else's patients so we can earn more money. This is all about working more collaboratively, and, you know, seeing the patient as the center of everything that we do, rather than the pound being at the center of everything that we do. So that's a little bit more about integrated care boards. And oh gosh, yes, I have to click this now. Next slide. Then we've got how NHS organisations were accountable. We used to have the Trust Development Authority and Monitor that used to monitor foundation trusts. The Trust Development Authority used to sort of account for the non-foundation trust. So we're not a foundation trust, and there are foundation trusts. But then as things got a little bit more bleaker for everybody, they decided to just have one monitoring agency, which was called NHS Improvement. And then NHS Improvement has now been merged within NHS England. And I think this is all around having just one kind of stream of accountability rather than having to report to lots of different people. You know, it's more efficient, and you've just got one organization that we need to report our results to, whether it's clinical, operational or financial. You know, we just report to NHS England, and they monitor us and they govern us through the integrated care systems. So that's just a little bit around kind of governance and structure and accountability. So all, you know, when we create our budgets and we do our accounting and our reporting, our month end and our annual accounts, they all have to go to the ICS, and then the ICS presents the position back to NHS England, and then the NHS England will collate all of the results of each of the systems together to see whether the NHS is still in balance or not. Yeah, and at this point, I think I'm going to have a little pause to allow you to have a comfort break for a few moments. But at the same time, I'm happy to answer some questions as well. I think there's some questions in the chat. So if you would like to, how would you like to do this, Katie? Shall we give everyone a comfort break while I have a read of the questions?
Yeah,
So we
good
get back.
idea.
Would everybody like to do that? Yeah. There's a question. It's got Nicola with their hand up. Don't know if that was a yes for a comfort break.
Would have been a thumb up.
Thumbs up. Oh no, that's great. So yeah, go and grab yourself a coffee, and we'll come back in say 5 minutes. Will that be okay?
Perfect. Thank you, Pam.
And that'll give me some time to read some of the comments in the chat box. I hope that's meeting people's expectations so far. I wasn't going to dive straight into spreadsheets. I think I would have bored everybody with an hour and a half of spreadsheets, I think. So having a bit of context is important. All right, then. See you back in a few minutes.
Fabulous. Thank you very much.
Thank you. Hope everyone's managed to have a little break and ready to come back and do the second part of this, kind of looking at what a budget is and just some examples of spreadsheets, really. So I'm going to try and keep this a bit interactive. I thought it might be useful because when I tend to do this training session, I do a bit of an interactive session about the kind of jargon that the accountants use, and just doing a bit of jargon busting, really. Now, I'm going to open this up to the audience rather than ask everybody what each of those mean. I'm going to ask if there's any jargons or acronyms on that slide that people are not quite sure about what that means, and whether, you know, you've heard that mentioned by your finance manager and perhaps not had the courage to ask what it means. Is there anything? Oh, just click to the new message. Oh, I got the presentation mode to work, by the way. I think it's working.
It's working.
Oh gosh, quite a few. All of them. All right then. I'm going to go through each one really quickly because just for time. FOT is forecast outturn. That's what we're predicting for the whole year. How much are we predicting to spend for the whole year? I&E is income and expenditure. So how much income do we get? How much expenditure do we have? YTD is year to date. So how much is our budget up to the current month? So let's just say the first half of the year. How much is our budget and how much have we spent against that? How much income have we earned? WTEs is our workforce, whole time equivalents, in terms of how many staff have we got employed, how much are we funded for. Your run rate, it's not anything to do with cricket, by the way. It's to do with how much we are spending on a monthly basis. So if you hear people talking about run rates, because there is quite a lot of focus, what is the trend of your spend? That's a good way of looking at it. How much are you spending every month? Are your costs increasing? Are they decreasing? Have you had spikes? You know, and understanding why things are increasing or where you've got spikes in your spend. HRG is a health resource group, and that relates to patient care in terms of to take an example, it's how we would get paid and how we cost services. So how much does a hip replacement cost? How much does a ECG cost? How much does a kidney transplant cost? You know, those kind of things are that grouped into kind of health resources, and there are quite a big long list of these if you went onto the NHS website and looked at the prices for each of the different procedures that we do. So it's costing of procedures, so we get an idea of where the resources are going, and a variance is just a difference. You know, what do we plan to spend and how much have we actually spent? How much income did we plan to earn and how much did we actually earn? And all of this is really important to understand, because when you get your budget statement, if you're a budget manager, you know, it's important to understand what this terminology is, because as accountants, sometimes, you know, we may speak in a language that our clinical and operational colleagues may not necessarily understand. So, as I said at the beginning, it's making sure we speak in a language that everybody kind of understands, and that's where training is really, really important. And then I hope I've answered everyone's questions. Oh yeah, there's loads of questions. Oh, someone's asked me to repeat forecast outturn. FOT is forecast outturn. So that means our predicted spend for the whole of the year. So when you have an annual budget, let's just say your service has an annual budget of £5 million. If you're predicting to spend £4.8 million because you've got vacancies, for example, or you're not doing the activity levels that you're expecting, you might be projecting an underspend, or your forecast outturn may be an overspend. You might be forecasting 5.5 million because you've got agency pressures and activity pressures. So it's understanding the reason why your forecast outturn is different to your annual budget, if that makes sense. I don't know how to do this, Katie. I've got loads of questions coming up on the chat, and I'm conscious that I would really love to answer all the questions. And should I try and do that as I go along, being conscious of what the questions are?
Yeah, whatever's best for you.
Yeah, okay. So thank you, all of you, for all of your comments and questions in the chat. I will do my utmost best to try and answer those as I go along through the slides. So the importance of run rates does depend on your budget, because what we don't want to see is, depends how organisations set their budget. Some organisations may say, well, actually, this is what we're actually spending, we'll adjust our budget accordingly, whereas other organisations may say that the budget is fixed, we can't change it, we're not going to do a zero base. You have to, you know, the budget is based on the service that you need to deliver. You need to be able to control the run rates and get them back to balance and back to budget. So it just depends on each organisation and how they do their budgeting. So I'm just going to move on because I've still got a few more slides and we only have 20 minutes left. So here's some examples of reports that we might send out to you as budget holders or managers, and these are fairly self-explanatory really, because all of these kind of reports include some type of financial information. So you may get an income and expenditure report that outlines how much income that your specialty or your service or your department is earning, depending on the patients that you're seeing and how much you're spending in terms of treating those patients, and obviously paying the staff as well. So these are just a few examples. It's not all of the different types of reports that we send out to our budget holders, but it's just an example of the kind of reports that we can provide. You know, there is lots and lots of financial information available. It's just, for us, it's just getting it into the best format that helps the needs of the service the best, in the best way possible, that allows them to manage their service and manage their finances. So we can provide information in any format. It just, you know, need feedback from the budget holders and the operational managers to advise us what's the best format for them. So there is lots of information contained in lots of different spreadsheets that we summarize into all these different reports. And then what I wanted to do was, oh, so there's a question, I think I've noticed a number of questions around block contracts and income reports. Yes, you should still get an income report, because regardless of whether you're on a block contract or not, the way our organisation works is that we have what's called an operational delivery plan, and what the operational delivery plan does is break down the level of activity that your service is needing to do to meet its elective recovery, which was, and I know I'm going to get really technical here, but you will have heard of the 104% and the 109%. Katie, is that something that people may have heard of? So to return back to COVID levels, what we're saying is, let's just say you did 100 patients before COVID, you have to do 109 patients now to get back to those same levels, to reduce all the waiting lists. And because we've got block contracts, what we try and do is say, well, this is the amount of patients you need to see 109 patients. This is the amount of income you would have received if we were under payment by results for those 109 patients, but actually we're only getting money for 100 of those patients, if that makes sense, under the block contract. So you can still get information from your income team or your contracting and commissioning team under the old payment by results method, if that kind of makes any sense. I don't know whether we will ever return back to payment by results, and I think yeah, I think we're in a different world where we've got kind of a mixture of block contracts and payment by results. Whether we will ever return, I really can't answer that question. A block contract is where you just get a fixed amount of money for your service. So if your service had, I don't know, £5 million for the patients that they saw before COVID, they would get £5 million, regardless of whether you saw more patients or less patients. You would just get a fixed amount of income. So it swings and roundabouts. Some will be over, some will be under, and it gets really, really complex. We do have another program called Demystifying Finance, which is a whole day. And that looks at all of these things in a bit more detail. So if I don't answer all your questions today, pardon me, but there is trying to cram everything into an hour and a half, but we do have a full day. It's called Demystifying NHS Finance, and I'll shout out to Aoife on the call today to send you the link to be able to register for that, because that does go into all of these things in a lot more detail, if that helps everybody. Okay, I'm going to move on, if that's okay, but just signposting you to another course that we do, which is a full day and looks at all of this in a lot more detail. Okay, right. So just really quickly, I'm hoping everybody knows what a budget is. You know, it's a plan or envelope of resources. We normally set them for a financial year from April to March, and it's agreed by NHS England and referred to as the plan. And the reason why we have budgets are to allow financial planning, monitoring and control. Coming back to what I was talking about earlier, that the organisation must stay in balance to allow the system to stay in balance, and then as a delegated authority, allowing the whole NHS to stay in balance also. So that's the reason why we have a budget and a plan, and just three kind of main aspects of a budget, where you have your pay budgets, which is the money and the staffing in whole time equivalents. So that's also referred to as your establishment, how many staff you have in post against that. And then you also have a non-pay budget, which is constituents are things like drugs, consumables, utilities, stationery, and other things like that. You know, all the things you need to be able to treat patients and run the service. And income, which is quite technical. and complex in our current world, where we don't currently have payment by results. We have a mixture of a fixed amount of money for the services that we provide, together with some element of incentives for doing more elective work. So that's the variable element. So we know that for emergencies, because we're trying to control our emergency demand, that's kind of under a fixed element, because that's forcing us to stay within the income block for emergencies. And I'll give you an example. If we note our emergency patients and emergency activity is increasing, what ends up happening is that more emergency patients will displace our elective patients. So because the emergency element is kind of like on a fixed term basis, say you're just going to get this money, you need to reduce your emergency demand if you can. It's kind of incentivizing us to do more elective work and create the space to do more elective work. And that's all about getting back to reducing our waiting times, our long waiting list, so that we can get back to the COVID levels, pre-COVID levels. So what you will find is that a lot of the way that the finance policy is framed is to kind of incentivize the way that we need to operationalize the way that we treat our patients, and be able to fund the right kind of work, if that makes sense. And then yeah, so income's really complicated. I think there's a separate session on income, because it's really complex. But we do have other income, such as teaching, training, Maydale, SIFT, and research money as well. So yeah, patient care income is it's another subject on its own. And then we have, as a budget holder, what is your responsibility is to make sure that you look after taxpayers' money. And really that's the responsibility in handling a fund that you're responsible for, and making sure that you identify and control any type of cost pressures and look for savings. And all of this comes out through your monthly meetings that you have with your finance managers. So that's just a little reminder of what a budget holder's responsibilities are, and it's kind of the same for in every organization. So and what we tend to do is tell people what we provide budget holder training, and most organizations do that to help you understand your spreadsheets and budgets in a bit more detail. So I'm going to share with you a really high level finance board report, and I've kept it fairly simple to begin with, because I think numbers can be quite scary. And what we're showing on the screen here is a summary financial position that we might present to our board. Let's say it is the surgery group, for example, because if a lot of organizations, a lot of hospitals are broken down into lots of different directorates or groups, we've got 7 groups in our organization, ranging from trauma and neuro to surgery and clinical support. So this is an example at a really high level. One group has a budget of total income is expected of £114 million. Their total expenditure budget is near to £70 million. So they're expecting, so if you look at that first column where it's got the plan, they're expecting a surplus with their total income and total expenditure of just under £45 million. But what's actually transpiring, and you've got that forecast outturn, sometimes that's abbreviated to FOT. So if you see FOT, that's what that means. So you've got your plan, your annual budget, your forecast, and your variance. And I'm going to give you some hints and tips here. If you always go to the bottom right hand corner, that will tell you the results of where your specialty or your group or your budget is performing at. So at the moment, if you look in the bottom right hand corner there, you've got in red brackets, you've got 3,407. So that's 3,004,007. Now it's in brackets. Brackets is bad when it's in a variance. And it's also red, which is saying that actually overall the position of that group is predicting to be a deficit of £3.4 million is what is predicted, and that is the forecast. Breaking that down a little bit, if you look at the top line, there is a second box to the right, which is the year to date. So that's just looking at the months year to date. But just for mathematical purposes, what that does is saying, well, okay, when you get your budget report or your statement, you say, well, actually, in the first 6 months or the first 9 months, I'm already overspent. Is there anything I can do to bring it back in balance? You've got time for the rest of the year to put in place any actions that you need to bring your plan back in balance, or your expenditure and your income back in balance. So at the bottom of those numbers, I've kind of explained in high level what might be driving that deficit. So you've got the 3 kind of lines of that financial statement that are driving that deficit. You've got an income underachievement of 2.2 million. So if you look at the first line where you've got total income, this service was meant to bring in £114 million worth of income. They're only projecting to bring in £112 million worth of income, probably due to block payments or whatever the complexities may be around the income. So they've got a shortfall of, I've rounded it up to £2.2 million. So that's one aspect of that deficit. Then their pay budget is £44 million, but they're expecting to spend £45 million, nearly £46 million. So they're projecting an overspend of £1.6 million there, if you round that up. Again, so that's another aspect of their overspend and the deficit position. Then you have also the non-pay budget, which is 25 million, and there's a small underspend. So 25.5, going to spend 25, you've got an underspend of 400k. Now you're underspending because you're not seeing the patients that you were meant to see. And so because your activity is lower, your income is lower, but your non-pay cost, your drugs and consumables to treat those patients is also lower. So you've got a fortuitous underspend there. And they're the things that are driving that forecast deficit. So that will help for you to understand if you have a financial position. Always go to the bottom right hand corner and see, okay, what's that telling me? It's telling me it's in brackets, it's bad, it's red, it's a deficit. What are the elements that are driving that? My income's down, my pay is up because I've got more agency, but I've not delivered my activity, so that's why I'm projecting a deficit. And the year-to-date position is the same principle, but just showing you partway through the year how that looks with some months to go. So why are red bracket amounts in the plan? Oh, that's just the way that we show our expenditure. It doesn't have to be in red brackets. It's just how we show the expenditure. The main thing to look at is the variance column, whether that's in brackets and whether it's red. That will tell you whether it's adverse or so whether it's positive or negative. So even though the non-pay is in brackets and it's red because it's expenditure, you've still got an underspend which is not in brackets because that's telling you that's favourable. The red brackets is telling you it's not favourable, it's bad, if that makes any sense. Okay, I'm just going to move on to the next slide, which I think is the last slide now. So this is an example spreadsheet of what you might have a budget statement And again, I wanted to keep this fairly simple because there can be so many numbers in there. And the main thing to do, this is an example really of a medical pay budget. And in each of your organizations, you will have these. It will tell you what the establishment is for each area, how many doctors you should have, what the budget is, and how much you've spent and how many you've got in post. So when we talk about pay budget, we're talking about pounds and whole time equivalents. So if you look at this, on this establishment, you should have 88.99 whole time equivalents. And sometimes it is a fraction because of the way the rotas work, and it works out a point of a PA or something like that. So you might have, it might not be a round number, just to say that because of the way the PAs are worked out. How many do you actually have in post? At the moment, it looks as though slightly over budget there. You've got 90.8 against an establishment of 88.9. It's not a lot in it. It's really about 1.2 whole times. And then you've got your budget for the month and how much you've spent in the month. And again, I would always go back to the bottom right hand corner of the variance and say, well, what is this telling me? It's telling me that, does anybody want to shout out whether it's underspent or overspent bottom line? Yeah.
Underspent.
Yeah. So that's underspent. Now I'm going to go through this really quickly. What we've got is, if you have a look in the variance column and see where are your biggest underspends, the biggest areas in black are in your consultants because they're your most highest paid staff, and you've actually got quite a lot of vacancies. You should be recruited up to 38.87, but you've only got 33 in post, which means that you've got an underspend because you're not spending that budget. You don't have the consultants in post that you should have, but at the same time, you're spending money on consultant locums. So that's an overspend because we don't budget for locums or agency. So this is what I was saying at the beginning, that when you look at the budget overall, it may be balanced, but then you have to go down into the detail and say, well, actually, I need to look at each line in detail and understand that actually I haven't recruited my consultants, I'm using locum, but I have a plan to recruit those consultants and reduce my locum or agency spend. And it's about understanding each of those lines. And it's the same with the junior doctors as well, where you've got career grades. You don't have any career grades in post, but you're actually using more registrars, for example, and so you're overspent on your registrar group than your career grades. And that's kind of just an example. I know I'm hoping you weren't there's a lot to spreadsheets, but that's the kind of the general principle, is that when you've got a budget or a spreadsheet in front of you, always look at the variance and try to understand what is driving that operationally, and what conversation do I need to have with my finance manager to understand my finances better, and what decisions do I need to make, what support do I need to be able to recruit and get my service back in balance. So that was just a snapshot of interpreting different budget statements and spreadsheets with the context of the whole of the NHS finances in there. I'm going to just pause only because we're at 12:30, and I didn't want to keep people holding on if they need to join other meetings. But if people do want to stay on, I'm happy to stay on for another 10 or 15 minutes to answer any questions. I'm not sure whether you need to close the session now or not.
Aoife, are you there? Do you want to confirm? Should we stop recording and then?
Yeah, we can stop the recording, and if people are happy to stay on, they can. But I'll just stop the recording now, and then we can obviously share the slides with everyone.
I've just popped a comment in the chat as well from us, Pam, just to say thanks so much, because that's a fab session. Obviously, people